they said, what the hell? If I have to die, then maybe I can die with my hand raised or with my head raised, right? And do something about it while waiting to die. And so they started claiming their place at the table.
Hi, I'm Caitlin.
And I'm Clarinda.
And this is Not Just Patients,
a podcast where we break barriers to meaningful patient involvement in healthcare.
Thank you so much for tuning in. Our guest on today's episode is Tamás Bereczky, who is here to talk about the history, evolution, and future of patient engagement.
I have the very difficult task of introducing Tamás briefly because honestly, his body of work and accomplishments could take up the whole episode. If you've been working in patient engagement or advocacy for any length of time, you've probably heard of or crossed paths with Tamás some way. He's been living with HIV since 2003, and he's just been a stalwart in patient advocacy, serving on various boards and committees, such as the European AIDS Treatment Group, and coordinating large-scale studies on topics of interest to his patient and medical community. Tamás also conducts and publishes academic research on patient involvement in R&D, HTA, etc., and develops and delivers training on patient engagement. In fact, Caitlin and I met Tamás a few months ago in the EUPATI patient expert training program, which we were both participants of, and Tamás was one of the faculty. Tamás, it's really exciting to have you here. Thank you for being here.
Thank you for having me. It's really good to be here.
Let's start at the very beginning. Tamás, could you talk us through the origins of patient advocacy and engagement?
So I would say that formally about 10 years ago, but informally or in a less widespread fashion, the idea that development of drugs and other treatment options, so not only drugs, but as we call them, health technologies. Mm-hmm. So the development of health technologies is best done with the involvement of the people who actually use these technologies, mm-hmm. or people on whom these technologies are used. So the realization that patients need to have an input in order to have meaningful outcomes is not very recent, but the systematic use of certain methodologies and processes to make sure that it actually happens is relatively recent still. So that's where these 10 years that I mentioned come into play. But how it all started was actually about 35 years ago, even maybe 40 now, in the HIV and AIDS movement. But that was a very unique time because that was a time when there was a very unique confluence, co-occurrence of various social movements. The Black liberation movement, the gay liberation movement, the third wave of feminism, all of these social movements occurred at the same time, which had a reason, and the reason was the emergence and spread of neoliberal capitalism. And as a response to this, there was this massive wave of different social movements, which were all about liberation. And that's a coincidence, but at the same time, the AIDS epidemic started. And so there were these bunch of people, primarily white middle-class gay men, who were left without a choice. Their choice was death. That was the only choice. So there was no alternative, there was no treatment. And also, there was no research or development done in order to get a cure or a treatment for HIV and AIDS. And so riding the wave of these liberation movements, these people, they said, what the hell? If I have to die, then maybe I can die with my hand raised or with my head raised, right? And do something about it while waiting to die. And so they started claiming their place at the table. And they did this with various methods. And these various methods until today remain important elements or parts of the advocacy toolbox that all of us or any patient organization or patient group would use. But they did a lot of direct action, demonstrations, marches, sit-ins, die-ins, But they also immediately started with a different strand of strategy, which was learning about HIV, because no one else was interested in what was going on. So learning about HIV, the biology, the pathology of HIV and AIDS, learning about the social collaterals, like why is it that it's gay men who get infected? So they immediately realized that there must be a reason, and this reason then can be described in a scientific fashion. So parallel to this movement towards or in hard sciences, immediately there was another strand of activism and advocacy in social sciences. And also a profound realization that if we want to make our voices heard, then it's not enough just to shout, but we also have to learn the language of the other stakeholders, which is the language of science. Mm. And also this was associated with a lot of pride. So people said that it's not magic. You don't become a doctor or you don't become a researcher because a deity descended and appointed you to be, but because you studied. And if you could learn it, then I can learn it too. And so that was also the starting point of patient education, which was self-education at the time primarily. But that's how it started to grow, that it's not enough to complain, but you also have to be able to support this with facts and knowledge, numbers. And that's the root, that's where this whole thing then emerged from or grew out from, and very rapidly also actually spread to other disease areas. So I would not want to claim that this is like the only, or the merit of only the HIV and AIDS communities, because very, very quickly, the breast cancer advocacy movement also started. Cystic fibrosis patients also were there in the front line, and hematology. So it was then this realization was then very quickly there in other patient constituencies as well.
Yeah, it's so interesting to hear you talk about that and how it started and actually how long it took for people to really get behind it as patients and get involved. It's astounding, like you say, that, you know, all of these products and innovations are happening for these people, but the people who it affects or directly impacts have not necessarily always been involved. Like you say, there was almost a political movement where I suppose it also combined with the big innovations in healthcare, and suddenly some quite stark inequalities came through, and those communities really pushed and fought for their own rights, really. And that was a big movement, and obviously a lot has changed since then, but it's evolved a lot over time as well to be, I suppose, maybe more sophisticated, if you'd agree. So I was wondering if you could speak a little bit about how over the past 30, 40 years almost, how patient engagement has evolved.
You're right. It is more sophisticated, but it's not less political. It is also, it's probably even more complicated or more difficult, challenging maybe, because this paradigm in which patients are on the bottom of the hierarchy is very, very old. This didn't start recently, right? So this was now. With the sophistication, I think that what happened, especially, I would say like 10, 12 years ago, what happened that on the political level in the European Union, especially, there was a sudden realization that in order to improve the acceptability of healthcare systems and also to reduce the burden on healthcare systems, people, citizens, including patients, must be involved in a much better, deeper, and more meaningful way. Now, mind you, this goes hand in hand with something that we've seen globally and has also been endorsed by some of the supranational or international organizations like the WHO, which is an increased familialization and privatization of healthcare and social care, by which I mean more and more tasks and responsibilities that were originally taken up, assumed, and taken care of by the state, by the welfare state, especially in the West, in the US, also in Western Europe. More and more of these tasks and responsibilities are being pushed out into families and onto the individuals. Like you keep hearing about self-care, the importance of self-care, the importance of prevention, how you can make sure that traditional knowledge is more integrated into healthcare, like, the knowledge of indigenous tribes, how you can work with this informal knowledge and make that part of the entire care landscape. But this is not possible unless people are aware of what needs to be done, and unless they understand how this whole thing works. So this realization occurred then in the EU, I would say about 12 years ago, when the idea of the Patients Academy emerged. And then EUPATI, so the Patients Academy, was in fact the first program or project of the European Commission that was actively conceived for and supported for patient education. And this increased general knowledge or awareness of patients, including obviously caregivers, in order to allow this gradual transition to happen. So that, and I don't want to go there to debate whether it's good or bad that the welfare state is changing or certain tasks are disappearing. But at the same time, I think that, so to say, the backlash, so that people have to learn, patient communities have to learn about what to do, what can be done, what should be done, is a good thing after all, because it's empowering, it's emancipatory. And that's also what we've been doing for more like 2 decades now. So that's...
I think the origin story is extremely powerful. And I mean, it really takes something like that, right? A movement like that to start something like this that continues for years and years and decades beyond the people who started it. Tell us your own story about how you got involved. You've been involved a long time.
Well, yes, but my story is not heroic at all. It's very banal. So I contracted HIV because I was stupid. Something very, very typical happened to me, which still keeps happening to people who live with HIV, even in the richer countries, which is I think I was overconfident and kind of stupid. And I said that this could never happen to me, right? So, I can do whatever I want. This is not, HIV it's not my illness. HIV is something that sex workers get, or drug users, or people who lead promiscuous lives. And I assumed that this did not apply to me. Actually, it did very much apply to me. So there was a certain kind of blindness in this as well, which I think still happens to a lot of people. Also, I was in love and I was blind to what was going on around me. And I did not realize that my then partner was HIV positive, and he didn't tell me about that. And so I contracted HIV. But also at the time I already had a child, a daughter. She was 9 at the time. And I also had a pretty good career as a linguist, as a translator, as an interpreter. And it was going very well. And so I knew that I had a lot to do. I had a lot of unfinished business. And I could not abandon my child. And I loved my work. I really liked what I was doing at the time. And I like living. I wanted to stay alive. Right? So dying or giving up was not a choice. Having said that, it was very, very difficult. It still is I still do quite a bit of consulting or counseling rather for people living with HIV and drug users. And it's as difficult as it was. It will always be difficult. It's not it's not like you get your diagnosis. And I think this goes for all diseases. So it's not like you get your diagnosis and you shrug and move on. This doesn't work that way. It's not just not like that. So a whole year passed, I think, when I was mourning my losses and trying to piece my life back together. And then I realized that another reason why I was so dumb was because there was no information available on HIV and AIDS in Hungarian, in my native language. Or there was very little, and also that was very outdated and scary. And then I started blogging and doing short videos already. So that was 18 years ago. So that was when YouTube first appeared and Gmail was new. And, so there was sounds today like ancient times, but it wasn't so long ago, by the way. And
it was in our lifetime too. So We're not that young.
Yeah, but come on, come on. But no, it's just because it's also ubiquitous, right? Isn't it? So, and people tend to forget that actually, I mean, I worked like for years and years and years. I used an electric typewriter. So it was like there were no computers; they were not invented.
That was before our time, though.
Don't do that to him, Clarinda. He'll leave. Wait till the end of the recording, at least.
No, he's a proud grandfather. It's okay to be a little ageist
Actually,
here.
guess what? I'm 1.5 grandfathers because my daughter's pregnant and another granddaughter is on the way.
Fantastic. Oh, congratulations.
Quite thrilling, isn't it? So I started with blogging but I could not, and I did not want to, and I think I wasn't courageous enough at the time to come out as an HIV positive person. So I did this all under a pseudonym or several pseudonyms actually, and kind of being semi-public about it, but never really coming out until after. Actually, one day it was my daughter, about 3 years into this work, when she one afternoon she showed me my blog and asked me straight away, "Is this you?" And then I came out to my daughter, and then soon after that, I gradually came out to everybody else as well. So it wasn't easy, but it also wasn't as difficult as for many of my peers. Many of my peers have a much rougher journey. And I really want to acknowledge that I was still lucky. I mean, I still remained a middle class white gay man, right? So with all the privileges and all the benefits and everything, and the choices, obviously, that I had, and these choices are denied to many of my peers. And so this realization that there's not enough information, this went together with a sense of responsibility. And then very soon after that, I joined the European AIDS Treatment Group, EATG, which is the network or alliance of people living with HIV across Europe, which spans the whole of WHO Europe. And then there, actually, this work career even took off because I became involved in a number of projects. EATG has traditionally been doing very interesting things, so it was easy to get engaged because these were exciting and interesting projects, and I wanted to be part of them. And then one thing followed the other, and here we are. So it's like, and also that's how I became involved in the Patients Academy, because EATG has been one of the sustaining partners of the Patients Academy there since its establishment. And so I then gradually worked more and more with the Patients Academy. And after all, I am an educator, so it was just a natural choice.
Yeah. Thanks so much for sharing that with so much honesty. I think that one thing that you said that's really important when you started out, you said your story is not heroic. I think that for people trying to understand patient advocacy, I think that that's a really important statement, because it can be seen as this, conquering all your difficulties and choosing to save the world. But that's not true, because by and large, for most of us, and I related a lot to your story, even the coming out part, as having a rare disease myself and not wanting to bring that to my professional life, or, not really wanting to tell people about it. It was so relatable. But I think for many of us, our journey into advocacy is about coming to terms with it ourselves. And honestly, it almost starts out as a selfish thing that we do to come to terms with it, and then it just one thing leads to another, and then we see that there is some power in this, and we want to do more, and once we start, then we want to do more. But it's not like we start out saying, I'm going to be the knight in shining armor for this community or anything like that.
No. And this is it's interesting that what you're saying, because what you've just described is actually subsumed under the statement of the personal is political, which was one of the key tenets of third wave feminism from the 80s, 90s onwards. But that doesn't mean that you are a superhero or you have to be a superhero. It's just that you need to lead an aware and conscious life. So just pay attention to what's happening to you and around you, and then it comes naturally. But if it's not your thing, that's also fine.
Yeah,
I think it's also important to tell people that not everybody has to be a patient advocate. It's fine if you're not. It's okay. It's okay. It's okay. Maybe your thing is just to talk to other people. Maybe not. Maybe your thing is to read what other people write about the disease or patient advocacy or whatever. I think there's one thing that nobody can left untouched, or one thing that should not leave anyone unconcerned, and that is that the system and people, including the healthcare system, will do things to you that you may not want to happen. And if you don't want that to happen, then you have to do something about it, because nobody else will. And maybe doing something about it is being in touch with other people, or asking them to do it for you, or relying on their work. And then there will be some of us who are more active and do things, and then there can be others who are less active, and that's fine.
Okay.
I think what's interesting as well just is that I think a lot of people who are advocates or representatives as well, it sounds strange because, people are suffering with an illness which isn't privileged. But I think within that space, a lot of people who are able to be educated and have been through something and have the skills and the voice to be able to support other people. All three of us on this call in some way have some sort of privilege. I know that you spoke to it, Tamás, about being in a privileged position, being sort of middle-class white man. And Clarinda and I have spoken about privilege in a sense that, well, we both have a rare disease, but we're at a point of privilege even having a diagnosis. And I think even though it is personally coming to terms with it, it's having the ability and the capacity to, an interest as well, to do something about it. And it's other people do it in different ways. We're trying to do it through a podcast, but I think it is really important to both engage patients, but also activate them to learn about their own health and help themselves and make sure they are pushing a little bit for their own rights and their own care. So I think we've talked a little bit about how patient engagement has evolved over time. Are there any developments that you've seen since being in the space that you're particularly happy about and I think have moved the cause in the right direction?
Yes, the whole thing. I mean, that this is still happening. This is unexpected, actually. Seriously, this is quite unexpected. We knew with EUPATI that what's been happening there is a good thing, but also we did it, right? So we've been doing it and we believe in this cause. So it was easy for us to believe that this is something good and meaningful and it should be successful. Yet the successes that the Patients Academy achieved was a surprise even to us. So with I think it's now 9 million individual users of the toolbox, and
Wow.
And all the graduate of the patient expert training course, yourselves included, and the exponential growth in the number of new recruits, like people who attend the course. This is a bit unexpected, but it's also very, very good. It's very reassuring. It's a nice surprise. The other thing that I think is going the right way, or has been going the right way, is actually the outcomes. Like all the things that these our peers have achieved with organizations or outside of organizations as individuals. The increased presence of patient advocates in decision-making bodies at the EMA, at the FDA, also at national authorities, this tremendous wave of new advocates and patient representatives working in HTA, and it's just beginning now, so it's going to grow even more. And honestly, what I also found quite surprising was how quickly and relatively easily the whole concept of patient involvement was adopted by the pharmaceutical industry. For a number of reasons, I tend to be a little bit skeptical about the industry, not just the pharmaceutical industry, but, so corporations in general. And after all, I did grow up behind the Iron Curtain in a communist country. So I come with different indoctrination. Yet that has never been an issue. I mean, there's an openness, there's a willingness, there's been a welcoming attitude in the industry towards working with patients more. Yes, we can debate about like implementation or the efficiency of how it goes, the models that are being used or the procedures. But the fact whether or not patients should be at the table is not, it's not debated. That's not debatable anymore,
it's
right?
not in dispute
at the pharmaceutical industry. If you go to academia, there the picture is very different. There's still a lot of work that needs to happen. Apparently, those systems, those hierarchies, those paradigms are much more rigid and less open to change. So that's more challenging or difficult. And the same applies to policymakers and state institutions like supervisory bodies or regulatory bodies, where again, due to bureaucracy and tradition, it's more difficult to push through this type of change, that you include citizens as equal partners in these discussions or in decisions rather. Okay. But all in all, I think we have all been pleasantly surprised by how quickly this movement has grown over the last 10 years.
Yeah, it is reassuring to see that direction that it's been taking. You did touch upon some of the pain points or some of the work that still needs to be done. Could you talk about how some of these challenges affect your own work?
Yes, I can talk about that for days, actually. So there are a couple of areas where it remains difficult. Some of these challenges are related to the nature of my illness. HIV still is and has been a stigmatizing disease. And while it may sound even, again, I have to use the word heroic, when I speak so openly about, living with HIV, being gay or bisexual, being a former substance user, and all that, I've never made a secret out of these features of my life or these labels that I live with, that I carry. But that doesn't mean that this has made my life easier. Not at all. So because I'm confronted with this, and this is very personal, and I will try to take a step back and maybe also look at the bigger picture. But for me, this has always been a challenge, because if I go to an event or if I'm engaged in some function, or even if I teach at a university or other institution, I'm there with all these labels. I'm there as a gay with AIDS, but I'm also there as a sociology PhD. I'm there as a person who uses or used drugs. I don't use drugs anymore, but as a person who has experience with drugs. But at the same time, I'm also there as a psychologist. And this is sometimes challenging because you very easily get discredited just because of who you are. Now, this actually is brilliantly described by a contemporary philosopher. Her name is Havi Carel, who lives in Bristol, who talks about the concept of epistemic injustice. So epistemic injustice, in a very simple terms, describes the phenomenon when a statement is judged not on the basis of its truth, but on the basis of who says the statement. So that the same truth stated by a doctor is believed, as opposed to the same truth not being believed if it is stated by a patient. This is like the basis of, or the basic concept of epistemic injustice. And that is something that we all in patient advocacy have struggled with. What are we? Are we cute patients that you can commiserate with and cry for those 15 minutes when you listen to us? Or are we experts? And that has implications, right? Because if you're expert and if you do expert work, then that should be credited and compensated and remunerated just the same as the work of any other expert. But that doesn't happen. And why doesn't it happen? Because you're a patient. So then what am I? Right? So it's like, it's unjust. It's unfair. And this, I think, takes more time until we achieve some sort of change here, or a solution that makes it easier or more just or less unjust. So, and again, I'm in a lucky position. Currently, I work at a patient organization, a major patient organization. So which is for people living with HIV. It's been established by people living with HIV, has been run by people living with HIV in Germany. It's home. It's a safe space. But only few of us are in such a lucky position, like in any disease area, right? So it's not especially, and it's especially true for stigmatizing illnesses, including visible illnesses like skin diseases is a huge problem. Obesity is a huge problem. So I think we're talking about stigma, we're talking about discrimination, which is there in all illnesses. It's always stigmatizing. And we're talking about the lack of proper support infrastructures for people to overcome this stigma and discrimination.
Thank you for speaking about all these existing challenges. They certainly resonated with me, and I can see Clarinda nodding along too. And it's actually kind of cool, everything you just said, because we've called this podcast Not Just Patients. Because, well, I mean, I personally didn't, I suppose, come out to a lot of people as having cystic fibrosis, because I don't consider it part of my identity. And I think when you put that there, you're right, a lot of people kind of maybe assume in a professional world the patient is sort of the softer side, or maybe even for a while it was a tick box exercise to say, look, we've spoken to a patient, but they're just sort of a citizen, they don't necessarily have expertise. But what we've written is, we are not just patients, we are people, and we are experts, we are change makers, and we are collaborators. And that resonated with us. And
by the way, may I add, you're also taxpayers. And I think that's a fundamental point, that you're active, productive, and valuable members of society. And this is sometimes forgotten.
It's interesting that you've brought that up, because I always think about the fact that, I'm going maybe on a tangent here, so we can...
That's fine. I love tangents.
Great. I think when you're talking about outcomes, for whether it's health outcomes or even business outcomes, if we're talking industry, or societal outcomes if we're in the government, when patients are firstly activated, and secondly that care system and the treatments and innovations in place have been developed with patients in mind, they will be more successful than if patients are not involved. And that has an implication, meaning that people are healthier and they can contribute better to society, and they live longer and take more of your drugs and spend more of your money and everything. So while I think it is obviously really important to think about health as something that's very personal, and obviously we want people to live longer and better lives, it also makes for a better society in so many different ways. I think health touches everything. And my disease doesn't just impact me, it impacts my friends and my family and my colleagues, everyone. That's why speaking about all the different perspectives and all the different stakeholders who are involved is important to realise how big it is.
But you've also just delivered the perfect explanation for why this is political. This is a very, very, very political issue. But that's good. That shouldn't be scary. That's just good.
Okay, so Tamás, we spoke quite a bit about some of the challenges to patient engagement currently. Do you know of initiatives that are specifically looking to overcome some of these challenges?
Yes, there are some certain communities, organizations that have been doing a huge amount of work to come to an even better organization of these communities. So first of all, the European Patients Forum, EPF, has played a very important role in this for many years. They are the umbrella for patient organizations in Europe. And we tend to forget that actually there are tens of thousands of patient organizations in Europe, small ones, like what you also mentioned here, that yes, there's a couple dozen large, powerful organizations, but the bulk of patient organizations are small groups of maybe a dozen people or even fewer. And EPF is the umbrella to all of them. As long as they subscribe to EPF's objectives, they are welcome to join and enjoy the benefits of being part of a large network. Now, something similar has been happening with IAPO, the International Alliance of Patient Organizations, which sits in London and in Delhi. And they have also done a lot of very conscious, targeted organizational work to bring patient constituencies together along certain shared objectives, such as reinventing healthcare after the pandemic, or trying to understand what telehealth and the digitalization of healthcare means from a patient perspective. And I'm bringing these examples because all of they try to achieve more cooperation across disease areas, because there's a lot of unnecessary and unhealthy competition across patient groups and disease areas as well. And this is usually about like who gets more money, who gets more attention, who gets more support, who's more in the limelight. And yes, it's true that not everything and not every organization or every disease area can always be supported with the same intensity across the board all the time. That's probably impossible. And priorities need to be set. And I think it's a legitimate struggle to say that your disease area is a priority or should be. Yet this also leads to unnecessary competition and a fragmentation of resources. And so, for example, again, the Patients Academy, EUPATI, has done a lot to overcome this by bringing people together and giving them a chance to talk about what is common to all of us. Because at first sight, this may not always be self-explanatory, right? So this is like, what is common between cystic fibrosis and chronic myeloid leukemia? And yes, there's a bunch of things that are joint challenges and that are in common. But this needs to be discussed to come to common denominators and to decide what is it that we can do together, what is it that we should do together.
Right.
And fortunately, there are some initiatives that realize this and try to make sure that there's an exchange of information, communication, and coordinated work across these different disease areas. Coming to a unified global patient movement, that's a long way from here still. But that's something that we need. So that's something that we would need somewhere down the road.
I think to speak to the point you made about similarities between diseases, and I was just thinking about it between the three of us. You have AIDS, which affects your immune system. I have an autoimmune disease and I'm on immunosuppressants. So I have a suppressed immune system, and Caitlin has cystic fibrosis, where the immune system is suppressed and you are more susceptible to infection. And just between the three of us, you would not be able to identify correlations necessarily with those conditions, but it's just so obvious that there are important learnings that could be shared across communities. I think that's powerful.
I think what's really nice though, and what you said about the EUPATI kind of doing a higher level thing that isn't disease specific, is we went to the training and we were in that room in October, and someone with a rare cancer from Mexico, for example, could ask a question and someone would have a similar experience or an analog from a completely other side of the world in a completely different disease area. And of course, there will be disease areas and there will be countries that are more advanced, where there's better access to the care in the patient engagement space. And I think what's really cool is all learning from each other and taking those kind of above disease learnings and helping each other and giving each other advice. And then it doesn't matter if our diseases are similar or if our healthcare systems are similar, as long as that overarching learning can be applied. And I think in a lot of situations it can. And I had a really nice experience a month or so after the training where one of the drugs for cystic fibrosis got a negative appraisal from NICE, which is the HTA in the UK. And someone else at the training had experience putting through a patient group response to that, and they helped me. And even though the diseases were totally different, it was really about the approach and the tactics used and what resonated and what didn't. And I think that's what's really cool. And unfortunately, like you say, there are some in some cases there are politics where people are thinking about, I want the funding over that that company or whatever. But I think for the most part, it's a really supportive community. And one of the reasons we're doing this podcast actually is to really learn from each other and communicate about the success stories and the challenges and start a conversation discussion. So I think that's something that hopefully will start to happen more and more.
That last sentence of yours is exactly what I wanted to say now. I mean, I wish a lot more of that could happen, but I think it just takes time, and we must find common topics and advocacy objectives and gradually build and grow structures, even organizations. I don't know. I don't have a plan, but I think that an infrastructure will be needed for patient communities to talk to each other more and to interact more and do advocacy together.
I think that's a dream we all share. So switching tracks, Tamás, we'd love to know more about your own work. Could you share some of the initiatives you've been involved in?
Where do I begin? So I've been doing now, fortunately, a bunch of really interesting stuff. So working at the Deutsche AIDS-Hilfe. Deutsche AIDS-Hilfe is the umbrella organization of HIV and AIDS-related charities in Germany. And they run various departments, services obviously for people who live with HIV, but also services for sex workers, male and female, for trans people, trans individuals, regardless of HIV, because trans people in general are more at risk of contracting HIV than non-trans people. And the list goes on and on. Also educational courses for doctors and other healthcare professionals. And they also run research projects. And one of those research projects is called EMIS, the European MSM Internet Survey. So this is a major undertaking. It's hardcore sociology, which looks at the physical, sexual, and mental health of men who have sex with men in Europe, including trans and cis men. Anyone who identifies as a man having sex with men is welcome to complete this survey. This is the third round. In the last round in 2017, we had more than 130,000 participants in this survey. So it's massive.
Wow.
From Europe. And this time we run this survey in 46 countries and 35 languages. And the data are being collected now, so I don't know what the numbers will be, but we're quite optimistic that again we will be able to go beyond 100,000 participants. Now, this is co-funded by the European Center for Disease Prevention and Control, so ECDC, and 9 governments from Europe, and also more than 50 community organizations working in HIV or in gay health or in trans health. So it's a very broad coalition of organizations, funders, and contributors.
That's so cool.
It's very cool. It's a very cool project, actually. So I'm one of the coordinators of this project. So that's one thing I've been doing. I also do a lot of teaching with EUPATI, so courses for patients, but also for the industry, because a very similar course to what you went through, but a shorter version of that is offered to people working at the industry. So I teach those courses, or some of those courses rather, and I also develop materials for these courses. And there's a third interesting and important point or project that I'm involved in, and I'm the coordinator of that one too. It's called CORE. It's funded by the European Commission, and it is about, and you will see how this all comes full circle. this project is about building the capacities of community-based and community-led organizations in the European Union to provide services to patients, to people in the areas of HIV, viral hepatitis, tuberculosis, and sexually transmitted illnesses. So what's been happening here is that for several years now, actually for 10 years at least, these community organizations actually concretely working in healthcare have done a tremendous job. We know from the statistics that in countries like Greece, Spain, Portugal, Cyprus, about 70% of new HIV diagnoses are found in community organizations and community, we call them checkpoints. These are places, physical places where people can go and get tested. And they don't just get a test, but they also get counseling and, like signposting services to where to go. And they are specifically designed to be low threshold and welcoming for anyone. And also they are operated and run by community members. So this would be people who live with HIV or people who use drugs or sex workers sitting there in these offices, offering services to their peers in a systematic way with a systematic and coordinated methodology. And this particular project, and I think it's tremendously progressive from the European Union that they support this kind of initiative, and it's not the only one. So they support the similar initiatives, that they realize the value and the importance of these services. Because what happens here is you realize that you want to get an HIV test, and then you could go to the clinic and get tested, but the clinic closes at 5 and you work until 6. Mm-hmm. So what do? You can't take a day off every time you want to get tested, right? But the checkpoints open at 5 p.m. and they are open Perfect. In the evening or overnight. Mm-hmm. And you can go there and you can ask honest questions, and you will not get discriminating questions, because it's your peers who sit there. It's other gay men, it's other sex workers, it's other trans folks. I mean, you can be honest with them.
Yeah.
So I just took over this project 2 months ago from a colleague who left our organization, and I find it tremendously interesting, and it's also going quite well. And that's why I say that it all comes full circle, so that if you want to do this, then you can do it. It can be done. There are good examples. There are best practices. You will always find examples like this for how it can be done, even if the circumstances are difficult and challenging, and but others have already found a way, and we can learn from that, and we can adapt those learnings to other disease areas as well. And also because this project and a bunch of others that have been run by the community are about reversing stigma and injustice and discrimination. Mm-hmm. So when you think about or talk about health experts, then a transgender sex worker is not your first idea. Yet, when it comes to providing expert healthcare to sex workers or trans individuals, those are the exact people who will know what to do and how to do it. They are the experts. And projects like this give an opportunity for them and for everyone else to be acknowledged as experts and to do good for the communities and for society.
I think that's hugely empowering.
And like you said, again, these kind of projects, it's really cool to hear about. And I'm sure people listening will think that could be relevant for what I'm doing. It's almost an analog. And the main thing is we don't want to reinvent the wheel. It's not efficient to do that when there's existing learnings and things out there. So the more we can learn from each other, the more effective and efficient we can be. So that's really cool. So we've talked a lot about the history of patient engagement and how it's evolved and the projects that are going on at the moment. So we wanted to know, what changes do you expect or hope for in patient engagement over the next 5 years?
What I expect and what I hope for are not the same things.
Two separate questions then.
What I expect is that there will be a growing need for patient experts like you and other EUPATI fellows across the board, because regulators are just realizing how important and valuable this is, so they will need people. So I expect a bit of a panic. How can we meet this demand? Because at the same time, demand is also growing on the patient side. So more and more people want to be trained, and demand is growing also on the industry side. So we need to find ways how to scale up this type of work. I also expect even more services in healthcare and social care to be spun off into civil society, which will again increase the need for us to be involved and to be on top of our business. Because more and more, healthcare systems are in trouble everywhere in the world, and more we will be left to our own devices. That's what we've seen emerging during the pandemic and after the pandemic. And it's only starting. I don't think that this is going to end soon. So I think that there will be more and more pressure for patient constituencies to provide services. And the other thing I expect is, which is a good thing, I think, is that the conversation will grow as well, so that there will be more and more talk about what is it that civil society can do, what is it that it cannot do or shouldn't, and how this involvement in science and research can be strengthened and deepened, be made more profound. Yeah, I guess those are more or less my expectations. Parallel to that, we've also seen an interesting emergence of a new market, of a new business, which is the professional patient consultant. I did that myself for a couple of years and then stopped it last year, which introduces a completely new dimension of professionalization and competition. So we'll see how that evolves, because it's very new. We don't know where that takes us. But there's an increasing number of companies established by patient experts that work as consultants, and they provide consulting services in patient involvement or around patient involvement. And so it will be interesting to see to what extent they can retain an advocacy profile and to what extent they will become suppliers or subcontractors to the pharmaceutical and other industries, IT industry, data industries especially. So that's what's been happening in my view. And if you ask me about my hopes, this will sound weird, but I really hope that there will be no war. It's just this simple, because that will, wars always affect vulnerable populations a lot more profoundly than others, and patients are most of the time vulnerable. Just to say one thing, a war will disrupt the supply of medicine and care. And we've seen in Ukraine how much trouble that brings. And I also hope that we will work together more, that we will talk to each other more, that we can overcome competition and this meaningless struggle around resources and claim our rights and our justice. But I'm an idealist. I'm not a revolutionary exactly, but I'm a total idealist.
Cool. And would you say that your long-term dream for patient engagement is similar, on these themes?
You mean personally? I think I just realized that I don't want to leave it. I want to keep doing this, so that this is something I want to keep doing. Non-personally or professionally, whatever is the right term. If you ask me about like a vision, that would be that knowledgeable and empowered patient representatives with integrity are truly involved in decision making and development, so that they don't just, as one of you, and I don't remember who said this, but that we can truly overcome tokenism. And it's not just that you have a patient there as a tick box exercise so that we have a patient, but instead that there's real cooperation, real co-creation, work done together. That would be my long-term vision. And not everybody will immediately be emancipated, and it's also, look at the women's rights movement. It's started such a long time ago, like more than 100 years ago, and we're still struggling. So I don't have very high expectations, but I want to see the needle move.
I think we can all agree on that to a certain extent.
I think so
Good to
too.
hear.
Yeah, yeah. And I hope that 60 years from now, when your granddaughter is on a podcast, she's talking about all that's been achieved over these years. Yeah.
That would be lovely. Actually, my daughter also works at a patient organization, so
Cool.
kind of runs in the family now. Yeah.
Good. So, firstly, it's been fantastic to have you on here, and I know that you said you don't see yourself as being heroic or anything, but I've certainly been really, really inspired by everything you do and everything you've spoken about. So, thanks so much for being on our podcast today. And I think just to finish off, we'd love to know if you can narrow it down to one piece of advice. What piece of advice would you share with other patient advocates?
Learning is fun. I think that's the bottom line. It's work, but it's fun, and it should be. Yes, this is work. Yes, it's serious. Yes, it's about life and death. It literally is about life and death, right? So
Yes, yes.
I totally acknowledge it. But still, it should be fun. It shouldn't be scary. It's something that should and can give a lot of pleasure and satisfaction, because you do something good for yourself and you do something good for society. And you don't have to think big. You don't have to change the world, and just do a little bit, do something. And you'll see that all of this adds up, and then we can move things forward. And that this movement or this work and this community will never be home for everyone. That wouldn't be possible. And after all, I also have a degree in psychology, so not everyone is compatible with everyone, right? So this is never cannot work. Yet there is a community. So if you feel like you need a community, and there is one, and you can try, maybe you find home here, because we need more people.
Yeah. And similarly, what would be your one piece of advice for stakeholders, industry, and otherwise looking to engage patients more?
Trust us. We know what we're talking about.
That's perfect.
Thanks so much, Tamás, for coming on. This has been really, really interesting and insightful, and we're really happy to have you on the podcast. So, Clarinda, just you and I now, and I thought we could just spend a minute or two reflecting on what we've learned today. So, out of everything that Tamás has spoken about today, what would be your key takeaway?
One of the things that stood out for me was the need for more cooperation and collaboration across disease areas. While diseases might seem, not to have any similarities, but it's clear that there are many learnings that can be transferred. And unfortunately, that is limited by competition, even within disease areas and across disease areas.
Yeah, I totally agree. And actually, I was really interested by the history of patient engagement and how it started, and it's evolving quite quickly, but also thinking about it's not perfect yet. It's not a perfect situation. There's still far to go. And the way that we do that is we need to collaborate more with each other in the patient community, and also collaborate better with other stakeholders. And there's still a little bit of a way to go in that aspect.
Yes, definitely. And when you talk about collaboration, one other thing that comes to mind is what Tamás said about how relatively easily this concept of patient engagement was adopted by the industry, but not necessarily as much by academia or policymakers. And I think that those would be interesting angles to explore on future episodes.
Yeah, I'm definitely interested to delve into that a little bit more. And I think that sums up the episode nicely.
Well, thanks for listening, everyone. This has been Not Just Patients with our guest, Tamás Bereczky, and your hosts, Caitlin Rich and Clarinda Cerejo.